Hello, I'm Dr. Ashley Ross. I'm a professor of urology with Northwestern Medicine, also the clinical director of our Polsky Urologic Cancer Institute, the head of our clinical outcomes and clinical trial unit for urology, and co-director of our minimally invasive urologic oncology fellowship. I'm a prostate cancer expert, and I thought I would talk to you today about an interesting recent case of prostate cancer recurrence and treatment after ablative therapy. This is a 63-year-old gentleman who came to see me, but when he was 62, he was diagnosed with intermediate risk, clinically localized prostate cancer at an outside institution. This is a picture of his MRI. On the left here, you see the gentleman in what's called sagittal view. This is where we divide the body sort of up and down. And you can see his tailbone here, rectum is here. The urine in his bladder is white, and the urine goes through the prostate and out from the prostate into the penile urethra, which is here. In his prostate on MRI, they found a lesion consistent with prostate cancer. And if I cut him sort of like a loaf of bread with this dotted line here and put his images on the right side, this is an image from an MRI that uses sort of a water diffusion to look at like where are things more dense, because that's where more cancer could be. And you could see in this area on now his right side with his legs coming towards us, which ended up being the area of intermediate risk prostate cancer. So it's clinically localized intermediate risk prostate cancer on the right side. He was interested in preserving his quality of life as much as possible. And so he opted for a clinical trial that was using an ablative modality that sometimes is used in routine practice as well, but it's called aquablation. He did that all at an outside institution. Before I go further, the question might be, why did he opt for that? As you may already know, standard treatment options for intermediate risk prostate cancer that needs treatment is either surgical removal, where we remove the entire gland, or radiation-based therapies, where we're either shining radiation on the prostate or maybe implanting radioactive seeds into the prostate. That's called brachytherapy. The prostate itself, after we've reproduced, doesn't really serve a lot of functions for us as males. It does contribute to the ejaculate, may help support the sperm during fertilization, but it doesn't really do anything beyond contributing that fluid to the ejaculate. It, however, lives in sort of an important area of the body. If we again go to that picture on the left, the prostate, this circle here, is near the urinary sphincter, which is down at this area at the end of the prostate. It's near the bladder neck, which also can provide some urinary control. And below the prostate, kind of running on the left and right side of it, are nerves that control erection. They basically control the ability to get a firm erection, not penile sensation, not your libido, but ability to get a firm erection. So the prostate lives in this high rent district, and the idea of ablative therapies or focal therapies is, instead of removing the prostate or radiating the prostate, maybe they can destroy the tissue in a different way that's not going to cause as much collateral damage. Aquablation, which he had, was originally developed for treatment of prostate tissue, primarily for enlarged prostates. And I think the trial he went on is looking at repurposing that technology to ablate lesions, like cancerous lesions like this guy had. It tends to go from the inside of the prostate out. And so you could ask, like, is it really going to reach this peripheral lesion that's sort of more on the rim of the prostate? And you'd be right. He had that therapy. That therapy opened up the prostate and ablated some tissue. This is an MRI of him about a year after therapy. Again, he's cut down the center here on the right-hand side. Urine is in the bladder, white here, but also now extends with a larger cavity into the prostate, showing that some tissue has been ablated. But as we described, it didn't seem like they had ablated the cancer itself. So 1 year later, after his ablative low-intensity therapy, his PSA had risen slightly. His MRI showed the same right-sided lesion, maybe a little bit bigger, and he had a biopsy that confirmed that this was still intermediate risk prostate cancer in the area. And then he presented to me at Northwestern to talk about options, and we reviewed different options for him. And one of the options that I think should have been prioritized was what we did, which is a simple removal of the prostate gland with a robotic prostatectomy to remove his cancer in a definitive way. And I did that, and it did show that he had about 1.5 centimeters of unfavorable intermediate grade tumor in his prostate, at least in grade group 3. And luckily, it was organ confined with negative margins. The pathology itself is as stated. In terms of the surgical case itself, it was notable for adhesions of the prostate to surrounding structures and the sort of a deformity at the bladder neck. Certainly, these were related to his prior ablative therapy. So what are some of the discussion points we want to bring up? Many of you may be familiar with focal or ablative therapy. As imaging has gotten better with things like MRI, in some cases with things like PET PSMA, we can localize disease better, and we are more confident in where the cancer is in the prostate. We still have some questions that remain. In other words, like when a cancer occurs in a patient's prostate, say it is a unifocal cancer that's just in one area, is it going to be a good cancer that can be treated with focal therapy or an ablative therapy? Maybe. Some of the things that kind of help with that is that it is MRI visible, it's far enough away from important structures that control urination or sexual function, and moreover, that the patient has sort of one bad seed in the garden of their prostate, as opposed to someone with suspicion that maybe they're going to develop cancer in other areas at higher frequency than the average patient. For example, someone who might have a genetic abnormality like BRCA2, BRCA1. So, when you think about ablative or focal therapies, it is emerging. We definitely have ability to image and localize prostate cancer better. There are people with, focal disease like this patient we're talking about that could be good candidates for ablative or focal therapies that might reduce the morbidities or side effects of treatment. Now, when we think about these ablative technologies, they're not all the same. Some of them have been around and tested extensively, like cryoablation, which is freezing of prostate tissue, or high-intensity frequency ultrasound techniques that are heating prostate tissue. Some of them have been more recently developed and are under study, like the aquablation that we talked about here. There's another form of ultrasound ablation called TULSA that goes from the urethra out, and there's other forms like electroporation. And when we think about these technologies, it's important if you're going to select them as your initial treatment choice, or your doctor's going to select them with you, that you understand, like, well, what were they originally built for? Were they purpose built? Is this going to treat the tumor in the location that I have it? If you do have an ablative therapy, you do need follow-up. And this patient, thankfully, and he was on a clinical trial, had good follow-up. He had PSAs, he had an MRI, and, because there was worry that disease was persisting, he then had a subsequent biopsy. Now, when you have a patient who's had, or if you choose to have some sort of ablative or focal therapy, where instead of radiating the whole prostate or removing the whole prostate, you're sort of changing the cancer in it into scar tissue or something like this, you can still do subsequent treatments. Like in this case, I did a radical prostatectomy, and it's feasible. The difficulty of the procedure, however, varies with both the modality that was used by the prior provider or by the provider for their focal or ablative therapy, and the therapeutic extent. I think in this case, the aquablation, which sort of had a higher therapeutic extent and did a more sort of procedural work towards the bladder neck and the junction between the bladder and the prostate, added some challenges to this case. So I thank you for your time today. Again, an interesting case, kind of discussing emerging treatments for localized prostate cancer, that it can be successful in some patients. Patient selection is key. Choosing the right modality is key. There are backup options when these treatments fail, like happened in this case. And that, you want to pick the ideal option for you for the first step. You want to make that first step your best step. And it's important that you and your provider have a thoughtful discussion of what your goals of care are, and what are the clear outcomes of your disease. Thank you again. It was a pleasure talking to you today.